Yes.
I would like to say thank you so much for giving me opportunity to talk about this important topic, okay, in this challenging situation. So now I think we will start. So my issue. Okay. Okay. Okay, now I can see. Okay, thank you. Okay, so in this section, I will go through. So why the new normal for tuberculosis? And so because the in fact new normal is required for any other public health diseases or even our lifestyle, our way of living. So today we will focus mainly for the tuberculosis. And then, so what are the opportunities, potential issues, and mitigation measures surrounding this new norm? Next, please. Okay, so why I will go on with the next slide. Thank you. So first, let's have a look at the burden of the tuberculosis and COVID globally as well as the Philippines. So as we see on the global map for the tuberculosis, the incidence, you see that our southern hemisphere is heavily, burdened, and then Philippines ranked as the fourth, highest burdened country, okay, all over the world. So that's why it's important for the Philippines as well. And then in the whole world, there are around 1.8 billion of the population who are infected with TB, but it may or may not, manifest as a disease. But among them, 10 million people fell ill with TB and 1.2 million died. So that's mean 12% case fatality rate. And on top of that, we have the issue with the drug-resistant TB problem, which is the which we call multi-drug resistant TB or rifampicin-resistant drug-resistant TB. So for Philippines specific, in a year, there are an estimate of 1 million Filipinos likely to have active TB disease. Okay, I'm not talking about latent TB infection, it's only active TB disease yet. But among them, in 2018, only 345,000 cases were reported. According to the national TB target, not based on this prevalence, based on the incidence, 36% of active TB disease are missed to report or missed to diagnose. So among them, more than 22,000 TB patients died. So, which is very similar to the global, trend. But when we look at the COVID, you can see that the difference already. How the COVID has got attention, even though the number of the case fatality rate, which is only 6.7%, and majority of the cases are asymptomatic or pre-symptomatic. But it was declared as pandemic. So because of that, national government also declared as a public health emergency. So based on how this political highness, shape our control, that the program design and the design, as well as the national government respond to what a disease difference as well. So when a disease is declared as national public health emergency or global, public health emergency or pandemic, then the attention or the investment, human resources, funding, everything, and the political shape. Hello? Can you know here? Hello? That pattern, so which you will see, later on. Okay. Hello. Okay. Hello. Can you hear me?
Yes, sir. Yes. Yes.
Oh, sorry. Okay.
Yes, Dr.
I hear some background noise. That's why. Okay. So in the next slide, so it shows that depending on the how pandemic is declared, even though despite TB has been with us for more than 70,000 years, okay, COVID is only with us only in humans. Look at this rapid policy response. We don't have it yet. Okay, the resource mobilization, it's very slow. and for COVID, it was very rapid. And the same thing for the development of diagnosis. Okay, we have this rapid molecular diagnosis tool only in 2012, but for COVID, it developed within weeks. So already so many testing platforms. And then availability of treatment, we have tools that make people cure of TB. But despite that, certainly we don't really get the optimal stage of TB control yet. And so for the COVID, there are a lot of trials ongoing. So more than hundreds of the trials ongoing all over the world. And then availability of vaccine. So we have vaccine, but it has very limited efficacy. For the adult, it varies from the 30% to the only up to 55%, but it's work in the children to more than 88% to prevent from the severe form of TB, like such as TB meningitis. So for COVID, the research are ongoing. So it may come by the end of the year, or some are optimistic that it may even we may even have the vaccine in September, but we're not sure. So in terms of funding gap, okay, so for TB, annually, we have the gap of 5 billion globally for the control as well as including the results. So 5 billion funding gap every year. But for COVID, currently, it's estimated from the World Trust, and the need is 8 billion. So the promise they have already got to do what 7 billion within this short period. Next slide, please. Next, please. Okay, so why now we will talk about why new normal is required. So let's look at how can we contain COVID. So according to the Cochrane Library modeling analysis, so quarantine alone can decrease the COVID disease 44 to 81%, and it can also substantially decrease the death rate as well. But if we combine with other measures, it's a much more, for example, the school closure or social distancing, it is much more effective. So if we do early measure on the quarantine, it is more cost effective as well. So when, according to the study, from the SARS study. But the issue we have is who have the disease, okay? Without doing the test, we do not know, or because the majority of COVID, patients, they are asymptomatic or pre-symptomatic at the beginning. Okay, so we do not exactly know how many will be really asymptomatic. So some say 5%, some cohorts say, some cohorts say even 80%. So because of that, if we cannot do mass population-based testing, okay, we still need to add up with the social distancing. Why? Because these asymptomatic or symptomatic people, they can transmit disease to the other people as well. So that's why quarantine alone is not enough. Social distancing will be still required. So because of that, this new normal, for the way of operating our activities, not only for TB, including our lifestyle, our daily lifestyle are required. Thank you. Next slide, please. Okay, so let's have a look at how much COVID has impacted on TB. It's impacted. I just put some examples like Philippines and China and India. So in China, when they compare with the same period of last year, okay, there were 20% drop in the month of February, and then in India there were 35% drop of case notification in the Q1 of 2020 compared to Q1 2019. In Philippines, it was 4.2% drop, but please take a note that the ECQ, okay, it's affected only from the second week of the March. So within 2 weeks of the quarantine, there was already 4.2% drop. So with the extension of ECQ, there will more likely to be drop as well. So why this drop happened? So you see that from the rapid assessment done by our USAID project, our project as well as our sister project, which is called TB platform. Our project is called TB Innovation Health System Strengthening Project. So we have done this rapid assessment, and we do only in a big 3 region, which is NCR region 3, region 4A, but TB platform is also working in Maram, so they also cover Maram. So we see that most of the activity from the case finding up to the case holding, plus specialist, treatment required for the adverse event encountered by the patient, those were affected, around more or less 50% for all of the tasks. Okay. So why, okay, so this is for the Philippines. So globally, so why this has happened? So why this has happened globally is the majority of TB hospital or TB wards or TB treatment center, they are converted to the COVID caring hospital, especially China cited strongly as well. And the healthcare workforce who are working in the TB, they are shifted to the COVID care, or either the other, including other healthcare workers, they are affected by COVID as well. According to the WHO report in April 21st, 35,000 healthcare workers are already infected by COVID. Okay, so why so units happen of this COVID infection to the healthcare workers? So because it can contribute to our double pandemic. If healthcare workers are gone, the healthcare, the whole healthcare system will collapse, not only for the COVID care. So it's mainly because of insufficient or lack of IPC training, infection prevention and control measure training, and the measures put in place, and lack of PPEs. So the other point I like to cite about is the laboratory. So in the laboratory for the COVID testing, the biosafety level 2 laboratory is required to safely test COVID tests. So because of the Philippine issue and memo that, okay, if a patient is suspicious of both COVID and TB, then sputum sample will be tested only after obtaining COVID result. Okay, because BSL-2 laboratory capacity is not available everywhere. Okay, so then it's further delay diagnosis of TB as well. So the other factor is more related to the patient care and from the patient factor, patient side, as well as commodity supply. And because of restricted movement, imposed by the ECQ, so it discouraged the population to go and seek care timely, because TB sinus symptoms are trivial. It's not really, the patient do not really take it seriously because they are only mild fever or mild cough. So they take it trivial. So they don't take, the care timely. And they are also faced with stigma to go to the health facility as well. Also the fear of disease as well. And the other thing cited, because it's very relevant to our discussion today, is China. They discussed about this because they converted many hospitals to the online or virtual hospital. So fever and pneumonia clinic, online clinic. But under the health insurance coverage, this digital healthcare service delivery does not cover. Okay. So next slide, please. Okay, so these were the existing impact, and what future impact is. It is done by the Stop TB partnerships and the partnering with the other the Hopkins University, Imperial College, and every Health with the support of USAID. And it is this study, it's a model study based on the data collected from 3 high TB burden countries, India, Kenya, and the Ukraine, so which cover most of the continents where TB is highly prevalent. And so from this, what we see in next 5-year times, we will have additional 6.3 million TB cases and additional 1.4 million death of TB cases if the the quarantine or isolation lockdown period lasts for 3 months, and the recovery time to start TB program to the previous stage. So if we take that much time, there will be that much big impact. So, but if we take less time, for example, 2-month lockdown and 2-month recovery, it is less. So it's only 3.1%. When we look at the compare, like for example, globally, if 2-month lockdown and 2-month recovery, it's only 3.1% impact. But if we take 3 months lockdown and the 10-month recovery, it's 10.7% impact on the TB incident. So it shows that the longer lockdown or the longer it takes recovery time, there will be the more negative impact on the TB patients. Next slide, please. But this table just to show you what factors are considered in this model study. Okay, so now, for us, I think it is really the time to leverage between COVID and TB with the new normal, because the experts and the ratio predicts that COVID may remain with us sometime at least, or some epidemiologists, even the experts, they are more pessimistic that it may remain with us like an endemic, like influenza. So we have to look at the way, to stay with normal life. And so the picture described that because of COVID, TB is pushed down. So we have to, make the balance, this pivot, by converging COVID and TB as an integrated service delivery program or control program. So why can we do so as integrated program? I will talk in next slide. Next slide, please. Next. No, I think we skipped one slide. Okay. So why we can say we can integrate? Because there are many similarity of the clinical features and risk factor between COVID and TB. For example, fever and cough. Okay, in terms of risk factor, male, age factor, diabetes, chronic kidney disease, cancer, close contact. So all these are common factor, both COVID and the TB. And in terms of transmission route, it's a respiratory droplet. And even though COVID has surface contact involved, and the diagnosis, the gene expert machine that we widely use in the Philippines as well as globally, this can also be done. This machine can also do COVID tests as well. So plus on the foundation for the TB program. So we have enabling policy, which I will talk later on, plus the staff on the ground. They are well experienced in conducting case finding activity, either active case finding or intensified case finding or passive case finding activity, contact tracing, and animal infection control measures, the TB preventive therapy, and how logistics support is done TB activity for the coordinators level. And Philippines has a very good foundation with the barangay healthcare worker, even though it may not be fully committed by the local government units. During my field visit, I saw that there are a big workforce of the barangay healthcare worker where you can, to whom we can utilize as health education activity, contact tracing activity, sample transport, and community-based care. So I mentioned here striders. Striders are the motorbike people who transport student sample from the health center to the diagnostic facility. So they are lay facility. And there are also digital technical, technologies which we can utilize across TB care. Some already utilize it in Philippines, but there are many more globally that are available. So because of that, we can do this integrated service delivery by doing co-screening, co-contact tracing, especially in a high COVID risk area, depending on which LGU has how much incident. And then co-diagnosis in high-risk groups such as male, more existing or diabetes who present with the same symptom. Okay? And a co-IPC measure, of course, by adding the requirement for COVID infection control measures such as social distancing and surface hygiene and the security triage of the COVID patient. And a shared diagnostic machine if required, but do not get robbed by the COVID program. And a co-infection and the co-infection is the patients who are co-infected with the both TB and COVID management and the community and home-based care of those both disease and co-logistic system setting up. So we should take this opportunity, riding on the highness of political will and urgency on COVID response, to high the TB and JEDA to make more political high-level commitment so that we can get more resource, allocation to TB response as well. So other additional measure that we can put in at the implementation level is, so by reducing visit of TB follow-up instead of doing weekly or monthly, and then synchronize clinical laboratory follow-up and drug refill system, and the student, collection at home. So this will help protect our healthcare worker by decongesting health facility, and also minimize the nosocomial, transmission in the health facility to the healthcare worker as well as to the patient, and also will decrease the workload of healthcare workers as well. Okay. Next slide, please. Next, please. Okay, so this is just to show how we can schedule the synchronized follow-up visit. So if we do monthly, we will have 7 trips. If we do every alternate month, we will have only 5 trips. Okay, next slide, please. Okay, so there may be a question about why we can do, usually the people always think that TB only cough, for more than 2 weeks is the more relevant for TB. But if we go for the cough for more than 2 weeks, which we usually define as chronic cough, okay, the sensitivity is pretty poor. You see that only 35%. But if we go for cough any duration, sensitivity can increase to 57%. So which helps us to detect more, TB cases, and not to miss the cases. And plus, TB can even be asymptomatic, so which is already evident by the National TB Tuberculosis Prevalence Survey conducted in the Philippines in 2016, which showed that chest X-ray is more sensitive than a symptom-based screening. If we rely only on the symptom, we may detect only 32% of cases, but if we use chest X-ray, we will detect 92% of the suspected TB cases. Next slide, please. Okay, so there are also enabling policy as well. The MOP, so which outline the policy and procedure, as well as current department memo, which issued just after COVID pandemic. Okay, which politically enable us that to continue all case of TB care and to utilize digital technologies such as checking advanced event by telephone and using chest X-ray as screening tool, and the use of the rapid diagnostic molecular test for the TB diagnosis, and to use all oral MDR TB treatment instead of injectables, so that the patient doesn't need to come to the health facility every day, and the community and home-based care is also allowed, and digital adherence technology, they are also allowed to use that as well. Next slide, please. Okay, so another enabling factor in the Philippines is there are a high proportion of population that use smartphone and internet. In 2020, according to this study, 45% of the Filipinos are utilizing smartphone and online. Next slide, please. Next slide. Okay. So this is what the WHO has laid out previously. So where we will utilize digital technologies in the TB control effort. So before it say only is patient care, mainly for the adherence, okay, and not beyond that. And the surveillance activity for the program through the reporting and recording system. Next slide, please. And for the programmatic management, for the logistic, monitoring. So this is one part. And For the healthcare workforce, it's for the e-learning. So this was old framework. But with the pandemic, so next slide, please. With COVID pandemic, Stop TB partnership has laid out, they make more elaborated. And then also the technology and the apps are more available that as well. So because of that, they modify this framework by the framework of patient journey. Okay, so in this framework, there are prevention of the outbreak and the screening. Okay, and a pre-presentation and pre-care seeking. Okay, so it's a beyond the patients reaching to the healthcare facilities, which is really good, proactive step. And then presentation and care seeking stage, and when they arrive at the health facility, triage, sample collection, and sample transport. And once they are identified as TB suspect, then we go for the TB diagnosis and other drug susceptibility testing for the MDR TB, and then we will move on to treatment initiation, and throughout the treatment course, the patient management. Then after treatment, there are also post follow-up treatment, which we follow up the patient for at least 1 year, and sometimes we go for 2 years. Thank you. Next slide, please. Okay, so here I would like to show you from this Stop TB list of the some example of available digital tools. But I want to highlight only to you that for each category, we see that there are many tools available. Okay, that means there are multiple providers, which we will talk about later on. Next slide, please. Okay, so before was more mainly for the program and the healthcare worker, but now it's mainly for the patients, teleradiology and artificial intelligence, reading by chest X-ray, and the lab, connected lab information connection system. So then, after diagnosis, patient care and the digital adherence, and the but they don't mention here about the advanced monitoring for the patient. So then, okay, there are the apps and the platform. So where are the evidence? Do they work well? Okay, the apps are there. Do they work well? So I am showing some evidences. So do they work or not? So there was a study done on how the lab test result from the laboratory machine. So with the connection of digital system, sending the result to the patient directly. So it was done in South Africa. And they put both the TB test, they utilize this for both TB test and viral load test for the HIV. They send the patient, so once the result is out, straight away, they auto sending the result with, urging the patient to come to the health facility. So compare with the control group, they see that 73% of the clients or patients, they see the result, versus only 8.6% of clients see the result within 7 days. So in terms of coming forward to the health facility to have care, within 1 week, 20% of the people who receive this SMS, they come to the health facility, versus only 8.6% of the control group come to the health facility. So another example is about the adherence. So it was done in multiple centers in UK. And with video dot, they see that within 2 months, 80% of patients swallow the drug, and whereas only 31% of clients, they can, to take the drug in front of healthcare worker. And so then, without your eyes, is it really the patients are taking or not? To check it, they do check with the sputum culture at month 2. There's no significant difference in the culture conversion for both groups. Okay, and they can also collect about the the adverse event. So among both groups, the same stomach pain, nausea, vomiting occurrence. So more or less it's the same, but in fact there's more reporting from the video dot group. Next slide, please. Okay, so this is another thing about the AI, artificial intelligence reading, on the chest X-ray, showing whether TB is suggestive. This chest X-ray is suggestive for TB or not. In fact, we had done a pilot, implementation in the Emmanuel Hospital in the Manila and the one in the Patagas Medical Center. So it works very well. We have like 1.8% TB case yield among the patients and 1.4% TB case yield among the patient companions. Okay, so but this was the study, and this was operation. Okay, we have already utilized it, but the study then was among the different software, whether does it work or not, is there any difference in the sensitivity or not. So they we compare among three platforms, three software. This is a pure AI, Cat4TB, and Lunit software. So among them, they see that sensitivity is more or less the same, for all software, but only depend on the population, the prevalence of TB, and just need to adjust the score, which score you want to utilize. And also, if you want to save the money, you can also adjust the score as well. So it is proven by the study as well. It is the reference is used as the gene expert result. So we can trust this AI reading because it's compare the AI reading versus professional radiologist reading. Okay? So in fact, it sees that one radiologist reading is only higher than AI, but the rest of radiologist reading is slightly inferior than AI reading. Okay? And other thing I like this one. This point I want to highlight because it's not happened in the many countries as well. This is online digital consultation. So with COVID, it's happened a lot, but with other chronic diseases like TB, will that work? Because I do not see any evidence for TB, so I brought about the asthma because asthma is also chronic disease as well. So it worked even in the children who are from 3 to 10 years old. They follow up for 10 years old by putting this intervention. So they see that most of the children, they visited for this, with the electronic consultation, e-consultation, more than 98% of them visited, consulted for this. And then when we compare the intervention group and control group, when they measure primary outcome as the symptom-free period in 2 weeks, there are no difference, okay, in terms of symptom-free period, but in fact, it's a more symptom-free in the intervention group. So the same thing for the hospitalization and the episode in the intervention group, it was lower compared to the control group. So it shows that e-consultation is effective. Next slide, please. Okay, so we have the evidence it works, but in reality for the implementation there are in fact quite a number of significant issues, and so let's look at how can we make those impossible to possible. Next slide, please. Okay, so there are the list of potential issues and possible solutions. So let's talk about first policy. So it is, I think, the main bottleneck in many countries, the policy on the use of different technologies. So then it's always said that we need to look at evidence. Okay, where are the evidence? So first, we bring any available evidence, and then we also further generate evidence. Through this, we advocate it. But sometimes we have to debate with the decision maker that should we wait, look at evidence, whereas there are ample evidence that works elsewhere in the other countries. So we should, based on our debate with the decision maker as well. And the next point is also very important, funding. And then many of us decision makers, they have concern over excessive health costs. You are imposing more health costs than now. So we are already short of the our budget, as I have mentioned before, about the funding gap. So So advocate the domestically as well as international funding. So domestically, me at the national level as well as LG, local government units level, we can advocate that as well. And then, and also to advocate to cover this digital the health, utilization cover under health insurance. And then when we advocate, we say that full economic value. So not only the health cost, that is direct cost covered by the program, but also consider the cost borne by the, so usually we call in TB program, it's called catastrophic cost to the patient. So to the patient's family and at the facility level. Then also acknowledge limited evidence based for the current care of model. So if it is face-to-face care model. The other issue is always privacy and security issue. So, okay, because of this issue, many it's not allowed to use many digital software or many digital apps. But it's very important, of course. So we have to ensure privacy with the due diligence, but it should not be a constraint that not to allow to the user to utilize it. So because of that, we have to make the balance between the putting diligence and measure on the privacy and security issue plus the user friendliness. And so for the user friendliness, so if we have the concern, the best example is a banking issue, which is the most sensitive for the business owner as well as to the customer. So even in there, if they can safeguard the security system, why we cannot do in the healthcare system? So we can, based on this example, we can install in there. Then the legal issue. So the legal issue is for the providers and the product registration. So provider is, let's say, an example about the medical practitioner. So there are, depending on each state, it may not allow medical licensure utilization across the state. But some country, it's covered, it nationalized is covered for the whole country. So if interstate licensure is an issue, so we have to make sure the flexibility in the policy and the implementing, anything a policy or a law, and then implementing in a fast way. And the same thing apply to the product registration to be faster. And the same thing for the claim of the health, the benefits. So health insurance benefits, it has to be streamlined in the credentialing the process as well. And at the same time, we also need to inform our clients that there can be this kind of caveat. And we have to inform, and we should better take consent to protect ourselves in terms of security. Next slide, please. So, okay. As I mentioned before, there are multiple providers. So to be able to facilitate these multiple providers, but not diverse, there may be some key selected provider. But if it is the healthcare providers, it is that are already listed as qualified providers. So make them this the information technology platform to make it interoperable for everybody. And then there will be quality issue. So I just bring the question about the quality issue for the care providers. If we combine remote care plus in-person care, so for example, for TB, we see the patient in the first visit when we initiate treatment, and at the time of diagnosis, may or may not need, but when we initiate treatment, it's important because we need to do baseline clinical examination and all the required lab tests. So we see one initial visit, but the other an important visit, we can do online consultation, and whereas like I have mentioned about the policy, DOH policy about telephoning, monitoring on the adherence and the adverse event monitoring can be followed. Okay, and other thing is so how can we know about the vital sign whatever? But nowadays it's a very good. We can get digital thermometer. We can have the digital blood pressure monitor. So these can be also made available to the client as well, and like the digital blood sugar monitor. So in some countries, this digital blood sugar monitor and test are also covered under health insurance. So we can think of that perspective. We can bring this perspective as well to make it visible. And then other things, the potential for abuse, it's mainly for the clinicians. So for example, it's overprescribing of narcotics. In that case, it is really very strong concern for many countries. So we can make it and require initial in-person visit or limit remote prescribing of high-risk medications, especially narcotics. Like we may do only weekly prescription. When we say e-consultation, it's also involve e-prescription. So that's why I'm talking about this in here. And also there is an issue with fragmentation of care among multiple providers because there will be specialists, there will be a lot of specialty, consultation as well, involvement as well. So in that case, there can be a system that can make interchangeable e-health records, so which make, among the providers to have better discussion as well as better care for the patient as well. So then the next, issue is a limited and fragmented insurance coverage. I think, for example, if we talk about the TB program, about field health coverage for TB, and many the clients are not satisfied with this because the field health package is very small. And so we have to advocate that. I think it's now already corrected. Okay, so we have to advocate for to improve access in many places as possible, plus to have a reasonable cost. And the last point is about social issue. So its social issue is made also for the healthcare workers as well as for the clients as well. So the clients, some clients may not be digital literate, or some clients they may not have the access to the internet, or they do not have any accessory to have access to the internet, like mobile phone, tablet or something like this. So in that case, okay, the government, national government should invest the broadband, installation across the nationwide as much as possible, and then providing smartphone to the clients and as well as to the healthcare worker, and also to cover communication costs to the healthcare workers. So I just want to give one very good example from the nationwide, coverage provided smartphone to the TB patients, which is in Belarus. So they give smartphone to every TB patient so that they can monitor adherence as well as the adverse drug event as well. So next slide, please. Okay, so to conclude, so now expert has predicted that COVID will remain with us. So the new normal strategy and practices are essential. So not to get back ourselves to end TB by 2035. Sorry, I got typo around 2035. There are a lot of funding gaps. So because of that, we need to carefully design to share the resources in a more cost-effective way, and then without strengthening public health system, there will be no health security. Okay. With one kind of investment in national health digital technology, it's not only for TB, but it will also facilitate to have readiness to effectively respond to the any public health emergency in the future, and even for the ongoing COVID response as well. Okay. Last slide, please. Okay, so now I'd like to call all of you. We need to act with a sense of urgency to achieve the goal of ending that TB and Philippines can also join in that journey. So I like to wish all of you TB-free PH can achieve rather sooner for the Philippines. Thank you so much, and Merry Christmas.